So as is important for all of us, I want to acknowledge that we're hosting this session on the unceded and ancestral territory of the Coast Salish peoples. That includes the territories of the Musqueam, the Squamish, the Tsleil-Waututh Nations, and the Métis Chartered Community of the Lower Mainland region. You around the province and in different parts of the world, because I noticed that one of our Nigerian colleagues is on the line, are on territories, and I think it behooves all of us at this time of increasing awareness and understanding to know more about the land and the space and the people of where you are. And so I'm a very grateful white settler, also from not from this country, and I'm very appreciative of being able to be here. Next slide. So CBD is not the cannabis product, but rather something to do with education, and it's really a great which is competence by design. Is that right?
Yes.
Right, so I got it right. But I want to introduce Dr. Howard Lim. So Howard is a medical oncologist at BC Cancer. His specialty is GI oncology, and he just come off a call with the surgical path and GI group this morning. He was the residency program director for 9 years and is currently one of our CBD leads at UBC postgraduate medical education. He's been involved in genomic-based research, ethics, and health policy relating to drug access, is a graduate of the UBC program, and we all remember him fondly because we wanted him to do nephrology, but he chose oncology as a medical resident, and has made amazing contributions to that field. So, but in addition, with respect to his knowledge and implementation of educational novel approaches, we've asked him today to talk to us about practical aspects. So Howie, thanks very much for making the time, and over to you.
Okay, I'm just going to share my screen here. Thanks so much for the lovely introduction. Too bad we can't do this in person. At some point we will be able to. And thank you very much for having me speak as well. So as Dr. Levin said, this is about sort of competency-based medical education, or competency by design. As an oncologist, I often do get asked if this is about marijuana, because I probably get asked about marijuana pretty much every day in clinic as well. So it is about education. And here are my disclosures. I have received honorariums from various pharmaceutical companies for consultancy work, as well as I'm an investigator on clinical trials here at BC Cancer as well. So the main objectives are going to be to introduce the core concepts of CBD, and then really discuss what these workplace assessments, also known as EPAs, or intrustable professional activities, and just to give a general overview of CBD in the clinical setting, and then outline the various CBD resources. So this is meant to be more of a practical understanding of what EPAs and how does this work, and then how does that data then feed into the general promotion or remediation of a resident as well. So why are we doing this? So why has the Royal College decided to switch over to this competency by design? And what the hope is that we're focusing on learning rather than a time-based system. And hopefully that we're going to ensure competence, still teach for excellence, but what we want to make sure is that we're still having competent skill sets. And we're supporting the physician skills and abilities to evolve through practice, responding to the patient's needs. But the biggest thing is addressing the biggest gap in the previous system, which is really this failure to fail culture of resident education. And I'm sure Abid has experienced this, well, not necessarily in nephrology, but we've had residents in the system where, you know, we kind of give them a 3s, they're passable, but no one's really written in the ITER like that they should fail, or we have often just passed residents through because the ITERs are such a high stakes system that there's really this failure to failure. We kind of do it at the very end of a rotation. We don't really give a formative feedback system to the residents to let them know how to improve to a certain extent. And hopefully this reduces the burden on faculties. There's a smoother credentialing and accreditation process. and increases accountability and promote transparency in the training. So it is going to be a hybrid model. I think time is still necessary, because if I gave everybody all the time in the world, you take all the time to train. So the number of years needed to complete a residency is not expected to change for the majority of residents. And so basically, this is where we are focusing on our residents, basically as they enter into residency or into subspecialties, such as nephrology. There's really 4 main components or stages. The first is transition to discipline, then the foundations, then core, then transition to practice. Now the examinations may start moving. We've certainly seen it in internal medicine, finally, after how many years that the internal medicine exam has now moved out of the subspecialty and into internal medicine earlier on, so that they're doing their Royal College examination. And then still there's a point of assessment as they transition to practice. And I do remember when I wrote my exam, you going, wow, I wish I actually read up on most of the stuff before my exam, so I had it during residency. So it does allow this actually knowledge acquisition to then be translated into a few more months of practice during residencies before they head out into practice as well. So some of the key things are these entrustable professional activities, which we'll discuss, increased support and faculty development tools, a national curriculum framework, and then an updated CanMeds framework. And I'll discuss CanMeds in a second, and what this means in terms of faculty as well as integrated education across the continuum. So if we look at the old system versus what we're trying to do now, the old system with the IDERs were most of the time, and I think faculty had a hard time with this, is they're very granular. And majority of the time they were not filled out timely at all. And it was hard. I will fully acknowledge I had a hard time with IDERs. And even as a program director, sometimes I didn't even fill out my IDERs on time, because it really broke it down into these CanMed goals. And sometimes not everything always fit in. And I admit, you're like, did they do a scholarly thing? And you're just like 3 or 4. And often it's the gestalt of how the resident was. And really, how often did you review the IDER with the residents? And they're very high stakes. Versus the EPAs are really what we call a work-based assessment. And it's really what most staff are used to doing in their head, is when you have a resident in your clinic, actually, were they doing something clinically relevant? So did they do their history and physical? Could they come up with a proper plan? Could they assess that problem? So could they actually, for nephrology, like, does this person have an acute kidney injury, whether the cause is, et cetera, and then what's the plan? So they're lower stakes and more frequent, and built in now are the CanMeds roles. So then to a certain extent now, faculty don't have to know all the CanMeds roles. I know near accreditation, I'd always show the CanMeds roles and say, okay, when the accreditors come in, this is what I need you to memorize, and this is what you need to say. Now they're actually embedded in. So when we looked at the traditional versus now what we call competency-based medical education, there's more data points for each rotation. These are lower stakes assessments, and hopefully we can identify residents who require additional support. And now it provides more explicit expectations. I think in the old system, well, still in both systems, there's that big document from the Royal College. These are all the learning points that you should get out of your residency. But within CBME now, this is linked to some of the EPAs and where you should be learning these on rotation. So there's a better curricular map for this. And I think how the EPA does help now is it's more of a shared mental model. And when we looked at the previous model of what we did, our previous model was kind of based on R4, R5, and it's supposed to be rotation specific, but it wasn't necessarily time specific. So there was not a clear idea of where the residents should be within an R4 or an R5. And I think residents had different expectations versus staff had different expectations of what an R4, R5 should be at. And even probably there's variability from staff to staff. So, and no one's fault on this. This is just how our system was. Whereas the EPA is really a defined task. It's really like a workplace OSCE in a way, and broken into some key milestones. And those are really what is needed to accomplish this task. And this is really how clinical faculty in their head have always evaluated residents. So when you have a brand new R4 on the service, or even most of the time it's like, well, when you come in, we expect you to be able to do a pretty good history and physical and have some basic internal medicine skills. And that would be an EPA probably for something called transition to discipline. Can they actually just function as a, take a good history and physical and come up with, identify key medical issues. And then with time, as they learn nephrology, understand some of those core competencies of dialysis or identifying kidney disease. And then as you move on, like what are the main competencies that would make you a consultant in nephrology? So that's how the EPAs work, is it's what are those tasks? And then it's actually quite transparent both to the staff and the attending. So this is just an example of an EPA. This isn't our oncology one. This is really assessing sort of ongoing care of the patient, and it shows the assessor, your observation was indirect or direct, the case type. Now, there are some contextual features, which I'll go into in a little later, where this was designed when we did this nationally. We wanted 5 observations of 2 different cancer sites over 3 different stages. It gets a little complicated and confusing for the residents and staff. So we have found actually some of these contextual features have been a little overwhelming in general. So I think it's better to have logbooks actually of where the residents are keeping track of the cases that they're seeing. And then you're trying to do the EPAs over time, really assessing their care. And that kind of takes care of some of these contextual features, which I'll explain in a second. In terms of achieving an EPA, it's really breaking it down into the milestones. So what are the components that you think a resident needs to do in order to achieve this? And it's no different than like an OSCE. When you're marking an OSCE, you have that checklist. It's the same sort of thing when you're doing an EPA as well. And then there is this score, what we call the O score. And I admit this can be a bit confusing, and how it is at the end of this assessment, do you feel, did you have to be there? Did you have to prompt them from time to time, or I did not need to be there? And some faculty feel like, well, especially in programs where they have R1s or R2s, they can never say, I never had to be there, but it should only be for whatever that discrete task is. So for an R4, I expect that I should not have to be there for history and physical. So I could leave them in the room. They should be able to do the history and physical, report that back to me, and come up with key problems. I'm not expecting an R4 to already operate as a consultant, so they shouldn't be able to do the oncology plan. So for this task, I really didn't have to be there. It doesn't mean I'm leaving them alone for the entire consultation. But as an R5 where they're at transition to practice, my expectation is at that point, I did not have to be there. So this I did not have to be there is just for that discrete task. It doesn't mean they're ready to go out to practice right then and there. And while I appreciate this is a very confusing score, and it was really developed for procedural specialties, so it's a little harder for the non-procedural subspecialties. This is where some confusion is for faculty. So that's been really the feedback as we've been talking to programs that have launched, is some faculty feel they really can't trust a junior resident with a task, and that only entrustment happens at a senior level. And this is where it really is about that task. At that point, you have to entrust a resident to this task. So some of the pitfalls about designing EPAs is that the tasks should be evaluated and observed. And so some of the EPAs that were created and we had to revamp some of these, is we had a lot of documentation ones. And so we have to revamp that because it couldn't really observe a documentation. So, but we still have it like where it's built in, so you have to still read it and then stick it into the system. Some places have research EPAs, and in oncology, we decided to put research more as a required training experience, and there's just a separate evaluation form versus an EPA. So we made our EPAs very more clinical practice-based. Some of the other EPA pitfalls really were that some programs just had too many. So anesthesia, when they first launched, they had something like almost like 67 EPAs. I think the total number of EPAs that residents had to finally do after 5 years was bordering almost on 1,000 to 1,500. And when the math worked out, they were at almost up to 5 to 10 EPAs a week, which just was not possible. So it did come down to some practicalities. The contextual features that people started to build into their EPAs also got confusing for people. So, and sometimes the numbers didn't add up. So I think in rehab medicine, it's like they have 5, you need to do 5 of the EPAs, but it requires 2 peds, 1 complex case, 2 geriatric, and 2 adult. So the numbers don't add up to way more than 5, yet you're supposed to do 5 of the EPAs. So it can be confusing and it's difficult to track. So this is where I think sometimes a logbook of having the residents log in what their breadth of experience is. So what type of patients are they expected to see over time. So I don't know, they need to see 20 hemodialysis patients, 10 peritoneal dialysis patients, et cetera. The other thing is it is helpful to have for the residents a map of where the EPAs could be done within each rotation. So in certain now oncology, we're a little bit easier because pretty much we're just team-based in terms of each tumor sites. Our EPAs kind of map out to almost every single tumor site. So what our map is, we expect you to try and do 1 EPA of a consultation, 2 of someone on chemotherapy, about 1 to 2 a month should be on breaking bad news, so that for each block, they have an understanding of like how many EPAs, and for each week, how many EPAs they should be trying to achieve. And they should be approaching staff for their EPAs as well. The staff can't totally know which EPAs should be done, but having said that, staff can also trigger an EPA. So the other day and most of the time I'll do this to my residents, is very first day of the rotation when they're on with me, and I can clearly see they're struggling, is I'll say, okay, we're going to do an EPA on this case, and I can give them the feedback and record it. They may not do well on that EPA, and that's fine, but this way they actually learn from the EPA. And I can tell them, okay, this is why you didn't do well on your chemotherapy prescribing. You forgot to put in the dosing weight, you miscalculated this part, but next time, now you know what to do. So next time we'll do the EPA again in about a week's time. And as long as that's corrected, you'll achieve your EPA. This is the oncology set. This is really how many EPAs our residents need. So transition to discipline, we're really only expecting 2 for them to assess and manage a patient in the outpatient clinic. And you can see our numbers aren't too bad. In foundation, this equates to about 1 to 2 per week. And in core, it's about 2 to 3 per week. Now, I will acknowledge these numbers, and like every program, are really pretty much, to a certain extent, arbitrary. And none of this has been validated. And there's been lots of confusion across programs in general. It's like, well, when you're saying like 10 EPAs, is that 10 EPAs where they passed, so they get 4 or 5s? Is it a 5, or is this 10 total? And really, these numbers are meant to be now, I think, more of a guideline of how many EPAs we sort of expect for the resident to try to achieve, so that we have enough data points to hopefully, as part of the data set, to promote or remediate residents. Now, in some cases, you may say, you may have a resident that's done 8 of them and they're all excellent, and you know summatively that this resident is excellent. That's fine. So it is up to the program to decide what makes sense and how much data makes sense with each resident. IDERs are still actually part of the process as a summative assessment. So we have changed our IDERs, and this is our basic IDER now. And it's basically, is the resident progressing, and just what are the strengths, areas of improvement, any concerns about professionalism. And the reason why IDERs are still needed is you need a summative assessment of the resident after they're done their rotation. So the EPAs are really these small biopsies over the rotation, but there still isn't a summative assessment if you just rely purely on the EPAs. And that's why the IDER is still needed at the end. to provide this overall gestalt for the resident to say, okay, this, despite, it's just to be done in conjunction. And then there's also your required training experiences. These are experiences that aren't valuable, but still necessary. So one of ours is like, we need to teach residents about clinical trials, and we want them exposed to enrollment and follow-up of clinical trial patients. We didn't make an EPA because our clinical trials can be very fluid, and there may be procedures where the residents just need to be exposed to it, but they can't actually participate per se because they're not on the training logs, et cetera. What we're trying to do is allow the system to be flexible to accommodate the differences between the programs. Otherwise, all the programs become the same. So when things were being designed, especially inpatient, not every program in the country in medical oncology has an inpatient program. So we had to make sure the system was flexible. Because the other thing is there is diversity across our programs, and we don't want a system that drives everything to be so homogeneous that we lose that diversity, because that's not the point of an educational program. I think there's a standard that we should all be meeting, but we should all be allowed to be different so that the residents can choose. And that's why, UBC is going to be different from Toronto or different from Calgary. The other newer thing that's now integrated are these 360 reviews. BC Cancer, we've always had 360 reviews of our residents. I used to sit down every 6 months with our charge nurse from the ward, our chemo nurse, our pharmacist, our head clerk, and we go through every single resident, do a 360 review. There is some discussion, should this include patient reviews of residents? I think you need to be careful there. Especially in oncology, where we're delivering a lot of bad news. I have witnessed residents do an excellent delivery of bad news, but sometimes it's not the news that patients want to hear. And they feel like, and then we get a shoot the messenger thing. So they give a resident bad review, or in our case, they fire us attending. So in that case, sometimes you're giving information to the patient about what they want to hear, not necessarily what they need to hear. So I have to admit, we haven't done patient reviews per se. If somebody has a letter about one of our residents, we do include it into their folder, but we don't mandate a patient review. And we're hoping that we can change the culture. And before the old system, it was this IDER was just pass fail. And there was always this discordance with the IDERs in the hallway conversations. I'd have patients give some residents all these 4s and say the resident was perfectly fine on the IDER, and then find me in the hallway and say, no, I'm really concerned about resident X because they can't do this, can't do that. And I'll be like, well, did you put in the IDER? Like, no, I didn't really want to do that because I didn't want to fail them, but it's up to you to do that. I'm like, well, I can't do that without the information. So, and because staff are really worried about this heavy stake or high stakes form, hopefully now that we move into an EPA where it's not so much high stakes, hopefully these sample observations give feedback to improve. And there are going to be times when the resident can't complete the task, and that's normal. Because if you think about how we raise children, when you teach your children to walk in stages, you give them feedback. Okay, good try, or you got your fingers there and they grab onto it and your back is sore from carrying them all around the place. We don't wait for them to start walking and then tell them how to walk. So in the end, our hope is that we have a better culture for learners to feel it's okay not to be perfect and to have meaningful feedback, and hopefully also for faculty to be able to feel comfortable giving, formative feedback, or even telling residents, look, you're not doing well here, but this is how to improve. And if you keep doing this, this is how you can achieve the task. So hopefully this makes it safer. I fully acknowledge this is what the system's hoping for. This still depends on the culture of the subspecialty as well. And this is where it comes down to coaching as well. So, RxOCR is really the CBD coaching model. So the first step is really establishing this education rapport between the resident and clinician. That's starting off your clinic saying, what are you hoping to get out of today's clinic? Are there EPAs that you wish to achieve? What I kind of do that more at the beginning of our rotation because normally the residents are with me for 4 weeks and I know they'll be in 1 or 2 of my clinics per week. I'll be like, okay, what haven't you seen? What do you want to see? What EPAs do you need to do over the next four weeks? And then just the expectations for each encounter. And then observe the residents directly or indirectly. I have to admit now with COVID, because my clinics are a mix of in-person and televisits, I can directly observe my residents doing televisits now because they'll be on the phone while I'm either typing my note in Cerner or seeing a patient. So I admit I'm multitasking a bit. I have to admit, still when I go directly in a room to see my residents do things, it's still probably maybe only once a block. So even I will admit to that degree of direct in the room observation, it's still a bit on the low side. But from the televisit side, I really hear what the residents are saying to my patients. So for better or worse, COVID's kind of helped with respect to that. And then next is really coaching the resident for the purposes of improvement and recording a summary of an encounter. And near the end of the block, I find most of the time I am telling the resident, hey, you did fine, that was great. And sometimes they are really quick. It's really at the beginning, I'm giving more feedback, but near the end, it's really very quick. And that's perfectly fine. If they're doing fine, it's perfectly fine to say, did a great job. Part of the issue about medicine is it is unusual where coaching and evaluations are done concurrently. If you think about sports, you have your coach, but evaluation is actually done by a scout. And so it's a little interesting where both your coaching and evaluation are done by the same person. But hopefully, by making the EPAs a lower stakes, this provides the mechanism for coaching. And I will admit, not every moment in your clinic has to be a teachable moment. And if things are fine, just say things are fine. Really trying to give feedback that is meaningful. There may be moments in the clinic where either A, you're too busy and it just has to be done at another time, or there may be moments where, especially where we've done one of our EPAs delivering bad news. Example was one of my residents, there was a end of life issue, young patient, we were in together, he gave the news. But both of us afterwards were it was a very heavy moment. It wasn't a great time to do a teachable moment. So I just said, we'll do your EPA, find me tomorrow afternoon when we both have a moment. And we decided to take time just for both of us to decompress first and then do the EPA the next day. And that's also fine. It's preferable for your EPAs to be done in the moment, but some of these can be done later on. This is where the system does it. So sometimes the residents will send it to you by email and then you log into the system that way. So the preference is in the moment, but I will admit there's sometimes you can't do it in the moment, and that's also fine. And it doesn't always have to be resident driven. So staff can also trigger an evaluation. So one of the big concerns about EPAs is faculty have always worried about, well, residents can choose who's going to give the best EPAs, or because there's always that staff person says everyone's awesome, and there's also that staff person says, you are who always gives out the low evaluations. So staff can always trigger an evaluation, and this is where I really come back to it's okay not to achieve an EPA. So I do a mix. In terms of the EPAs. So sometimes I trigger them, sometimes the resident will trigger them. If I trigger it, I fill it out. I also have the residents sometimes fill in their own EPA as a reflection piece to say what they think they've learned during their EPA. It also works for me because sometimes it tells me what I thought I taught the resident. So if they reflect what they think, how they think they've done, and what they think they've learned, I can read it and go, okay, good. I think this is what I actually taught you. And then what happens is I just sign in and double check things, add in some comments, and then sign off. So hopefully the main way now is that the resident can pull up the EPA on a device. Staff can also input the data, or some of my residents already have it pre-populated. While I've seen a patient, I come in and then I just sign off with my PIN. So most faculty should have their PINs. I admit half my faculty have forgot their PINs. So I'm trying to get my program admin to change their PINs or reset it to basically the local of their secretaries, because that's the one number you probably will never forget. First, it was my anniversary, but even then, sometimes I forget that too, and don't tell my wife. But the other option is a resident can send an EPA to the staff via email, and then the staff logs in, kind of the old way of doing things. I admit this way tends to fall off a bit. We're all inundated with emails. So it is better if it can be done in the moment in that sense. So, and again, it's really, there is value to having the resident filling in the EPA as a reflective piece and then having the staff review it. Entrada is the platform for EPAs. We are trying to move the ITERs over from 145 to Entrada, but you may still have your ITERs in 145. There are programs who have multiple systems. It's no different than how we have with CST and Cerner. There's Care Connect and Cerner. So unfortunately, we can't consolidate everything, but it still requires your campus-wide login and two-factor authentication. If you're having difficulties, please let us know. We do have a tech team, because I admit your CWL may not be updated from UBC. So it wasn't until I took on this position and finally got through my CWL, I noticed I'd been listed as a medical student for the last 12 years. And I was always logging in to RISE for all my ethics stuff. And so I was wondering why when I went to UBC, I never really had faculty discounts or anything. So now it's all updated that I'm actual faculty. I can now like sign my son up for tennis up there and I actually get a discount. And in Entrada, that's where you create your PIN as well. So you can just quickly, if you Google UBC and try to log in, or if you go to PGME, there is this login button as well. And takes you into Entrada, and basically your assessments should come up. If you need to do anything, if it's emailed to you, there will be a flag. And how do we promote residents is really through this competency committee. And this is the place where, so this is a committee selected by the RPC and the program director, where they review all the evaluations of the residents. So what we have done is really assign a faculty advisor for each resident to help check on their EPAs and ITERs and see how they're doing. When I was program director, what I did was the faculty advisor of the resident was the person who sat on the competency committee. So this way they're kind of reviewing the data and seeing if, trying to help make sure the resident's on track, but they review the data at the same time. So then this way they're not doing it all right before the meeting is about to start. They review all the data presented to the committee. Also, keep in mind, it's more than just the EPAs. I know we harp on the EPAs, but the EPAs are part of the overall data. So there's EPAs, there's the ITERs, we have our rounds presentations, there's teaching evaluations from the medical students and residents, and any other information that ends up in the resident's portfolio. And ultimately, the committee is responsible for the decision for promotion. So, and this is despite the established numbers for EPAs. And I know some programs are very dogmatic about those numbers. I don't think that's fair personally, because even in the old system, we never had all the residents' ITERs for promotion. I had residents who graduated and I'd still be getting ITERs on them like 6 months later. So ultimately, it's whether you have the data to defend promoting or remediating a resident. And so it's no different than anything else in life. It's just, do you have the breadth of data to truly justify your decision-making? So I don't think it's fair to hold this EPA and CBD program to this 100% standard, because we were never like that before. I think those numbers are really a guideline. The other thing is, this is not going to be perfect and it's going to take time. And I do see the culture slowly shifting. Now that internal medicine is launched, MedOnc launched a long time ago, and we were one, even the pilot programs, and it's taken a lot to get the momentum going. I admit COVID slowed us down, because all of a sudden for a while we weren't allowed to hand over devices and stuff like that. But and not everything has to be observed. If a resident can get one observation, maybe one time a week, that's probably 50 times more than they've ever had before. If you think about when we went through, I'm not too sure if many people ever observed me doing history physical, or I might have had maybe 2 or 3 observations during my entire internal medicine training. There will be more money. There is an increase in teaching money, as well as there's funding for the members of the competency committee as well. Incentive-wise, there is a pocket of money for implementation. So I use Starbucks cards as a carrot. So if you finish an EPA, I gave everybody a $10 Starbucks card. I think we've now blown the budget, but now unfortunately Starbucks is all gone near the cancer agency. So now I have to figure out a new method, but there's also a lot of modules if you want for faculty development. There are, there's this concept-based medical education. If you just Google it, there's a lot of key modules for self-study if you want to learn more as well. So in conclusion, just a summary, residents do need to have an EPA map. It just helps them know where they can achieve their EPAs. I do think the EPA numbers have sort of undermined the values of the EPAs. While it's helpful to have the residents have a goal, but I think it's so that they know what to do. I don't think we should like pin everything on that number. I also don't think the number should be the number of past EPAs, because that's where the residents will then only come to you if they're ready for success. And the EPA is meant to facilitate feedback. So I really just encourage my residents to try and get those EPA, try and do 2 to 3 a week so that they can continually get feedback, and really try and push that they should do it early in the rotation, because that's when you don't know things. And this is where, and we have blinders to our knowledge. So this is where a staff person can say, no, this is where you actually need to work on things. And then we can see it as they go through the rotation. I suggest a logbook to capture the breadth of their experience for the residents rather than trying to stick it into the EPAs. And then the EPAs are collected over time of the stage to really give you that picture of growth. The EPAs can be triggered by both the staff and the resident. And there's probably a lack of feedback because really sometimes the residents wait to do the EPA when they're ready to meet that successful number of EPAs. So then if they're really good, that's when you're going, well, you're fine. There is really not going to be any great feedback versus it doing it at the beginning of the rotation. I think that's where the feedback is more valuable. And the big question is, well, why are we doing this? Why are we spending more money? Well, I don't think we're going to make necessarily better doctors. I think the system, and I do think our training programs, we make excellent physicians. But I do think it's about creating a better environment, about providing feedback at the time when the learner truly needs it, and giving learners some confidence that someone has actually seen them do a task, and that we're now creating these assessments that are more meaningful in the clinic and aids in reflection for both the learners and the teachers. And then maybe we're now trying to change the culture of trying to be perfect, and maybe we can worry less about the imposter syndrome. I think some of us, where no one's seen us do something, they're like, I'm not sure, I think I'm doing things correctly, but no one's ever seen it. There's still that element of imposter syndrome. And I think hopefully if we create this environment where we can be more open about giving feedback, I think hopefully this will change some of that culture. And that's it. I opened up to questions.
Thanks, Howie. That was a great overview and a lot of thought. I guess I'll remind people to either raise their hands because it's often easier, and Brenda will unmute you, or put it in the chat or the Q&A, or the Q&A is easier for me. I mean, conceptually, I think this, like for all the reasons that you stated, this is a better system. But I still am a bit worried that it becomes a bit perfunctory. Like, I get sent an EPA after an event, I fill it out. Like, there's not really always an attempt to say, can we talk about this? It's like, could you fill out my EPA?
Yeah.
And like, I'm happy to do that, but what I would rather is, can we have a conversation? And then can you fill out my EPA? But it's now become like, you have to get them all racked up. I like your idea about a logbook. I don't know, I know it beats on the line whether or not we have such a thing, but I think that would be quite terrific. So those two things, and then Sunit can get unmuted and ask a question. But your thoughts on those comments? And
yeah, I totally agree with you. It is very much this. The system is a very still checkboxy system, and the residents are almost to a certain extent focused on the numbers. I need to get this EPA done. Can you just do
Right.
it? We've definitely lost how we had things in the old system, where some of that feedback was fairly organic and probably less pressure. I think the pendulum will hopefully swing back. And this is where, that's why I think if we put less emphasis on all those numbers, then hopefully that organic conversation comes back, with the EPA trying to provide a catalyst for it and some structure. But I agree that what you have mentioned is a huge problem with many programs. And I think it's how it's implemented and structured, because I think if you're using the numbers to drive it, then you lose the feedback portion.
Right. And I like what you suggested about, like, hey, this should be an EPA moment, like the physician suggesting it, as opposed to the resident or fellow saying, can, after the fact, this will be an EPA moment. Right. Sunit, you have your hand up. Over to you. Maybe turn on your...
Thanks, Adira. Thanks, Howard. One of the things, like medicine is kind of like software, right? It keeps getting updated, but do you go back and say, did the update make a difference? So I'm curious as to how we're going to evaluate this, because like when I'm more involved in the undergraduate education, but as medical students, most of them haven't had a direct observation apart from an OSCE exam. And I think that in the lower years of residency, R1s and R2s, this hasn't really improved direct observation. If we look at surgical teams or internal medicine teams, they sit around and, discuss cases in a sitting environment. But my observation hasn't been that they go back and actually see the patient together and have things reviewed at the bedside. So observation and verification doesn't really happen. Is there a way to look and see, has this system improved the actual number of observations? Because even in your slides, you mentioned that maybe even one observation is way more than they get. Have we actually shown that they're getting more?
Yeah, no, so we do have a program evaluation committee that's both happening at UBC, so that's forming, as well as nationally. So the Royal College has this program evaluation committee as well. So exactly what you've said, like, we've implemented this, what are the outputs and outcomes of this? So there is a survey that's going to go out to all program directors, I think residents and PAs, about, just like what you said, is there direct observation happening? It should be captured within the EPA. There is a drop box down on ours whether observation was direct or indirect. And so we're just trying to see through Entrada, through the main system, what are we capturing? But you're right. And I think, to your point, I think some of that direct observation, because it takes time, we've all been so clinically busy lately. The pandemic has not helped at all. And I think trying to do a direct observation, well, especially early on in the pandemic, where you almost had to be gowned and masked and everything. So we probably lost some of that due to the pandemic. That's where I said, observing televisits has been my way of doing more of my direct observation. But you're right, like the physical exam parts probably have gone a bit to the wayside, mainly due to workload. I'll be very honest, I think everyone's workload has significantly increased, not only because of our clinical workload, but let's be honest, Cerner implementation, CST implementation has been also a huge burden to everybody. So lots have been going on, and faculty are burnt out as well. So it's not just the system. There's other factors, I think, that go towards that as well. And we have to figure out how to address that. And once we get that feedback, is it the system or are there other things? Then how can we support faculties and programs so that we can have some more direct observation? But you bring up a very good point, and we're working on that.
Yeah, that's great. And Abid has a comment. Thanks. I like your comments regarding the number of EPAs, but the Royal College seems to fixate on that, particularly around the time of accreditation. If we can change the focus so we can decide if we have enough data rather than do we have the right number of assessments, that would be really good. And I think also the notion Abid's saying about promoting unsuccessful EPAs as formative, I think that's and I would agree with the beat. Like, I think that's something like, I remember someone saying to me, you learn as much from bad doctors as you do from good doctors. And you also learn as much from bad experiences or things that went wrong as you do from things that went right. And I don't, and to your final comments and your talk about how it's important to have a culture of learning and trial by error, as opposed to simply, am I doing it? Show here, let me show you that I did it right. You
Yeah,
know, because and so I think those are interesting things. And obviously, whenever you try to codify something, you end up with this numbers thing and tick the box. And so it's kind of at a bit of a juxtaposition. But yeah, those are Abid's comments. And then I think Peter has his hand up as well.
sure. So to Bede's comments, I think definitely around the Royal College, everyone's worried about accreditation. The Royal College document on competency committees does say that ultimately the decision to promote a resident is up to the competency committee of the program. And it does come back to, like, as long as you can demonstrate you have that data. In terms of that unsuccessful EPAs, I think to the residents, it's really showing them that we see that growth. So yeah, you may have 3 or 4 unsuccessful EPAs at the very beginning, but as long as you're becoming more successful, that's perfect. The other red flag for your program might be, you may have someone who's very successful and all of a sudden is getting unsuccessful EPAs. That might be a flag. Is what's going on? Is there a learning problem? Or there might be an issue in their personal life that's contributing to a performance. So that's another way the unsuccessful EPAs can flag things, is it's trying to help look at those trends as well.
Great. Peter.
Yeah, thanks, Howie. Can you hear me?
Yep.
Yeah.
Okay. So you talked about a little bit about that sort of Likert scale, or the I didn't need to be there kind of scale, right? Which is at the bottom of all the EPAs. But we haven't really had a whole lot of kind of orientation as a faculty as to the expectations on that scale. I think it was just put there, and people read it and say, okay, but not everyone has the same interpretation of it. And so maybe you could speak to, within your program, is there sort of a consensus about how this might be filled out? Is there an expectation that only a 5, I didn't need to be there, that's the only passing grade, the only acceptable EPA, and so therefore, are the residents feeling like they can only submit an EPA when they know they're going to get a 5? And if they get a 4, do they feel like they have not passed? So just speak on that overall, because that's an issue for a lot of programs, is that scale.
Yeah, to me, so you bring it, that has always been an issue of contention, I think, even across the country, and it's variable from program to program. Oncology, we do 4s and 5s, and I think that is now becoming more the standard. I think initially a lot of programs said it just should be a 5, and I think that was the line was drawn too much in the sand. I agree, this scale is confusing to many people, and it seems to work more with the surgeons than it does with us, to be quite frank. You talk to Rose Hadala, she hates that scale. And so sometimes internal medicine really goes based on the comments. Our initial scale was just pass fail. Do you think they passed? Or do you think they, or not pass fail, but like pass or just needs more work? This is what the Royal College really suggested. So it has taken a fair bit of education with respect to this scale. I admit, if we change the scale, then we're going to have to redo a lot of education. And I don't know if there's a single scale that works for everybody, to be quite frank. So for my staff people, I really say it again, emphasizing it's about really that task, whether you didn't have to be there or you might have just had to be in the room. That's also fine, especially on the R4 level. I can understand the discomfort of some staff, but it shouldn't be that I didn't have to be there because I think they're a staff person. I think that's where some of that confusion lies as well. So, but I totally agree. It's taken a long time to get around or to continue to with faculty development with respect to that.
Yeah, I guess kind of just adding, because there's a comment in the chat from one of the senior fellows. So it's one thing that the staff have been educated on EPAs, but how well have the residents
Yes.
especially the more senior has been educated as to what's the purpose. And I think, again, I'm going back to what some of the stuff you said, the culture, like it's been this change in the tools that we use to do evaluation without the groundswell of, to Sunit's point, like, so what was so broken that we had to change it to this without actually educating everybody as to the what and why, and the how. And so sometimes the wrong EPAs get sent, or the residents don't know. They just know they've got to have EPAs, so they keep sending them. So and that how are the residents being educated?
Yeah, so there is a residence so we have a resident subcommittee as part of the launch, but we fully acknowledge that I think we have focused so much on the faculty that we need to work on the residents more. And we try and do it more. I mean, in oncology, we definitely try and speak to them as R4s, but there needs to be a better education at the R1, R2 level. We're getting there, but I think and you're right, Megan, and I just realized this point that you're discussing is we talk to them about just getting EPAs, but you're very correct, because some of the senior residents and senior fellows are filling out EPAs. And we never taught you how to fill out an EPA actually as well. So I think we just assumed since you went through this, you're going through the system and been assessed, you would know how to do an EPA, but that's probably very faulty logic. So I really appreciate that point.
And not all the fellows necessarily trained here. A lot of our residents, and Megan is one of them, or fellows, came from another system. So especially for the fellowship programs, you'll often have people from outside, so yeah, it might be something worth thinking about how to do that in a formative way.
No, that's an excellent point.
Yeah. Any additional questions or thoughts? No, I've learned a lot. It's sort of made me rethink some of the education and evaluation concepts. So thanks for summarizing everything so nicely and clearly. I mean, you had over 30 people on a Friday morning listening, which is great, from around the province. We do have a distributed model where our fellows and residents are getting educated in other parts of the province. And so we did have representation from around, and I think this has been really, really useful.